Teşekkür ederim Selçuk Bey. And marhaba, iyi günler. Thank you for bringing me back for the 7th time to present one of these algorithms in your conferences. I'm today going to do generalized anxiety disorder for not older adults. This lecture is meant for younger adults, but we have a new one on older adults that we just published last year, which is significantly different, but this one is on younger adults. Now, I didn't figure out how to move to the next slide. Let's see. Uh-oh. Is this it?
This one.
Oh. So this is an update from the last time we published this algorithm in 2016. I'm very grateful to my collaborator, Harmony Abuela, who was the first author of the article. We have no financial relationships with any pharmaceutical or other firms to produce these algorithms. So here's an outline of what I'm going to cover in the talk today. First of all, why do we want a psychopharmacology algorithm for generalized anxiety disorder? Then we're going to talk about diagnosis, and it starts with diagnosis of the main disorder, but also comorbidities and other conditions that might change the basic algorithm. And then we'll talk about the main algorithm itself. We'll review FDA-approved medications in the United States for GAD, and also there are some off-label meds that have evidence we'll be discussing. We'll put some particular emphasis on the role of benzodiazepines, and then we'll get into more treatment-resistant cases toward the end. So to begin by introduction, generalized anxiety disorder. It's a chronic, debilitating condition, probably the most common anxiety disorder seen in primary care. 7 million Americans have it. Now, I want to make the point, as I do in all of these lectures on algorithms, psychopharmacology algorithms, that psychosocial interventions are very important. And this algorithm, though, only focuses on the use of medication. We thought it was too difficult a job, and continue to think it's too difficult, to try to produce algorithms taking into account all the treatments that you might have for these disorders. So the use of this algorithm is for people who you might want to use medication. You and the patient decide you want to use it. You decide it's desirable. This would help you decide what to choose. But it doesn't tell you whether you want to use meds first, or whether you want to use psychotherapy first, or both together. That's a more complicated decision, which we leave up to the clinicians. So to turn to the medications then that we have, there are a number of medications approved in the United States for GAD. We have 2 SSRIs that have that approval, escitalopram and paroxetine. We have 2 SNRIs, venlafaxine and duloxetine. We have 1 benzodiazepine, alprazolam, and 1 azapirone, buspirone. But we also have some off-label options that have apparent efficacy based on studies. So there's other SSRIs, other benzodiazepines, and then other drugs like hydroxyzine, pregabalin, bupropion, kava, lavender oil, and question mark about gabapentin might have roles in treating GAD. So to start with the diagnosis, we recommend that you use the DSM-5 TR criteria for diagnosing your GAD, because in general, all the psychopharmacology studies out there are based on treatment of patients that meet the criteria for different diagnoses, including this one. Now, this, though, is maybe one of the more difficult ones to carry out that goal, because the criteria for GAD have changed a lot over the years, probably more than any other major diagnosis in DSM-5 has it been changed over previous diagnoses. Like in DSM-3 was a radically different criteria. So we have to try to understand how that we apply the meds that were approved on the earlier criteria to the patient that has the current criteria. We'll say a little more about that later. But the current criteria involve excessive worry as the key symptom, occurring most days for at least 6 months. Over a 6-month period, it's difficult to control the worry, and you can have 3 out of 6 of the following additional symptoms. Only one item is required for children, and these are symptoms that mostly are overlapping with depression. But there are some somatic symptoms too. So being easily fatigued, difficulty concentrating, irritability, muscle tension, sleep disturbance, and feeling keyed up or on edge. And finally, you have to have significant impairment. Okay, so let's now turn to the algorithm, the beginning of it. So you have first met the criteria for GAD. Oops. Then you have to evaluate if there are any comorbidities that might affect the main algorithm. And they are over to the right, under there where it says Node 2A. And these are some of the points I want to make about those comorbidities. First one is sleep disturbance. Multiple contributing causes to insomnia out there. Your patient may have 3, 4, 5 different things going on at once that could contribute to their insomnia. So you try to sort those out and treat each one of the contributing causes to their insomnia with the evidence-based best treatments so that you're at least taking care of that, because some of the treatments for GAD may actually worsen sleep, like the SSRIs and SNRIs have significant percentage of patients, maybe 10 to 20%, whose sleep will get worse when you give them those drugs for their GAD. And for people like that, you may want to use more activating, more sedating agents that can work for GAD, like hydroxyzine and pregabalin. I might point out that pregabalin is not approved in the United States for GAD, but it is approved in Europe and some other places. So those might be preferred over the more standard recommendations of SSRIs and SNRIs if they need something more sedating. The other option is trying to manage the sleep problems from the SSRIs with adding something sedating. Trazodone has 2 controlled studies, adding it to an SSRI for insomnia, showing efficacy. Another option is to add benzodiazepines, but that's very problematic. We don't like to do that. They often cause rebound the night after you stop them, even after 1 dose, so that makes the patient think they have to take them forever. So we prefer trazodone. Now another group of people that we're considering under the heading of comorbidity and other conditions are older adults. And as I said, we have a whole new algorithm now for them. But a few points from that algorithm are on this slide. All medications, when you're using the elderly, are going to have more side effects, so you have to monitor them more closely. Then there's the SSRIs, which we will be recommending for at the top of both this and the older adult algorithm. The side effects will be greater, side effects such as gait impairment, so-called postural sway that older people get on SSRIs. Gastrointestinal bleeding can be more of an issue. Bone loss and low sodium levels, hyponatremia. So you need to watch for those issues. SNRIs, you have to watch out for the blood pressure elevation, particularly with venlafaxine. Now, pregabalin, as I mentioned, does have sleepiness, dizziness, and falls as an issue in the elderly. Actually, everything just about can cause more falls in the elderly. It's hard to say which of the various options are worse. It's something you just have to be very concerned about. And then there's hydroxyzine. Hydroxyzine, one of the drugs we're going to discuss in this algorithm today, but in the elderly, we want to avoid it. It's on Beer's list of drugs to be avoided in the elderly because it's very strong in anticholinergic effects. Benzodiazepines are another group generally you want to avoid in the elderly. You get more falls, of course, but also decreased respiratory drive, more auto accidents, they're more likely to be abused. Sedation is a problem. But at least they probably don't cause dementia or Alzheimer's disease. As Some have thought for quite a while, but the more recent studies fail to confirm that if you stop a benzodiazepine, there could be permanent cognitive problems that remain. And then quetiapine, another drug with metabolic risks, increase in QTC. We want to avoid it in older people. The third issue that involves populations, subpopulations with GAD are women who have the potential to become pregnant or who are pregnant and have GAD. Well, first of all, we do want to avoid benzodiazepines. They are a category D drug because of known problems with fetal impairment. Cleft palate is the abnormality that's been associated with benzodiazepines in fetuses that were born to women who became pregnant while on benzodiazepines. As far as the SSRIs and SNRIs, they're all category C, meaning that they have no specific abnormality that's been identified, except for paroxetine, which is category D also because of atrial septal defects. And a review about 10 years ago also found fluoxetine was almost as bad in causing that defect. So we probably want to avoid that as well in women who could become pregnant. Other problems with SSRIs in this population is the risk of postpartum hemorrhage. Premature delivery and other postnatal complications have been reported. But this might be confounding by indication. It could be that it's the women that got these SSRIs were more prone to those problems in the first place, and it's not the drug actually causing it. But these associations have been identified. Another subgroup of comorbid problems in people with GAD is if they have an active substance use problem while they also have their GAD. Alcohol and other kinds of drug dependencies. It's pretty common. Up to 15% or more of people with GAD have this. So what are the special considerations there? Avoid benzodiazepines. All the guidelines say this, avoid benzodiazepines in people who are using substances. But I see people being prescribed those all the time under those circumstances. This is an example of clinical practice not following what the guidelines recommend. Pregabalin is one of the drugs we've talked about. That is a Schedule IV drug that's prone to abuse, so probably you should avoid that as well in this group. Gabapentin doesn't have the Schedule IV designation, but probably has got the same amount of abuse potential, so we probably would avoid them as well in this group. I'll say more about these two drugs a little later. Major depression, comorbid with GAD, a very common problem. You can distinguish them, even though I gave you the criteria for GAD. They are somewhat similar to major depression, but not the same. You can tell whether they have both if you follow the criteria carefully. So what do we know about people that have this combination of problems? We know that their depression responds much less well when they have comorbid anxiety than when they don't, from the STAR-D study. So that's a problem. How are you going to treat them when the antidepressants may not work very well? Well, there may be a role for benzodiazepines to augment, on the anxiety side at least, these patients, and it's also possible that hydroxyzine and pregabalin could be helpful for them. All right, what about bipolar disorder? And thinking about bipolar depression to start with. What if they have that and generalized anxiety disorder? Well, you're going to see this commonly because the rates of GAD are higher in bipolar depression, even compared with unipolar depression. So I think you probably know what I'm going to say. Antidepressants, normally good for generalized anxiety disorder, like SSRIs, are not recommended for bipolar patients with anxiety, especially rapid cyclers and those who have mixed features. Mixed meaning they have their depression with some manic features in addition. You definitely want to avoid antidepressants for their GAD and go on to the other options that we offer in the algorithm, as you'll be shown shortly. Even if they're not random rapid cyclers or mixed, some studies find increased risk of mood destabilization with adding antidepressants in depression. So we think in general you should avoid it. What we do recommend, though, is first of all, treat the bipolar depression with our most evidence treatments. So we have 5 recommendations currently for our best treatments for bipolar depression. They are 4 antipsychotics, all have FDA approval: quetiapine, lorazepam, cariprazine, and lumateperone, all have FDA approval and are effective for bipolar depression. They should be at the top of your list of what to prescribe for them. But also, the combination of lithium and lamotrigine is a solid option. Either one alone is not particularly good for bipolar depression, but together they work better than either one alone. And often they'll need the lithium in there for covering mania. So we recommend the combination in addition to these other 4 choices. But for the anxiety, what would you give? Well, we would think hydroxyzine, pregabalin, or benzodiazepines would be the best choice, rather than the antidepressants that we recommend earlier in the algorithm for everybody else. Now, quetiapine is a good option because it was helpful in 20 out of 27 studies of bipolar patients who had high levels of anxiety in a review by Crapanzano. But quetiapine has a lot of side effects, so we don't have it at the top of the list. But it probably has significant efficacy for the comorbid anxiety in bipolar depression. And finally, we have post-traumatic stress disorder as a very common comorbidity with GAD, especially in the population that I see. I work in a veterans hospital in the United States, and we have lots of people with PTSD, and some of them also have generalized anxiety disorder. So what do we do? What's different for them? Well, prazosin is our best treatment for post-traumatic stress disorder. And it's a very useful add-on for their PTSD, for their nightmares, their disturbed awakenings. 6 out of 9 placebo-controlled studies have found prazosin to be effective. And in this meta-analysis by Lapis last year, they concluded that it was the best medication we have for PTSD. I would recommend you check with Raskin et al. In 2013. That's one of the 6 positive studies. That has a very clearly delineated dosing protocol. I discussed this algorithm for PTSD when I was in Antalya in your 2023 conference. Prazosin also helps with daytime symptoms of PTSD, according to a review by Hendrickson. But benzodiazepines, often used by clinicians, are thought not effective for PTSD and have high abuse potential. All right, now we're ready. Having considered those comorbidities and other conditions that could affect the algorithm, we're now going to show you the main algorithm for the uncomplicated case. And this is an overview of it, the bird's eye view. Now, this may be hard to see. I'm going to break it down section by section and show you blown up versions of it if you can't see this. But basically, just to show you in a few words, we do recommend an SSRI as the usual, first treatment, but then we've got these 6 alternatives to consider if you don't want to use an SSRI. And we also have these options if they get a partial response to the SSRI. But if you tried it and it didn't work, we would recommend a second trial of a different SSRI or duloxetine. And you have all these options. Some additional ones are added in. Once again, if you don't want, for some reason, to use your preferred SSRI. Many people don't like the side effects of SSRIs, like sexual side effects. And if that doesn't work, you're ready for a third trial, and we pick an SNRI now, and we have the same alternatives if you want to use something else, and a few more that we add at the very end of the algorithm. So that's the overview. Now let's break it down. So the first thing we recommend, first line recommendation, is have you given them an adequate trial of an SSRI? And if the answer is no, over here on the right, 3A, then we do recommend you go ahead with one. So here's the story on the SSRIs to give you a little more detail. So I already told you the 2 are FDA approved, But also sertraline has comparable efficacy in 3 randomized controlled trials. So that's okay. Citalopram, though, gives you the problem of QTc prolongation. It's fallen from favor. We don't use it because you can't go to certain doses, especially in older people, where the maximum is only 20. But overall, one can say about the SSRIs that they're not very effective. In a meta-analysis of all the SSRI studies, the effect size by Cohen's d was a pretty unimpressive 0.36. That means basically that it was about 36% better than the placebo, as one way of understanding what Cohen's d means. So that's a modest benefit. You can't expect great things from the SSRIs, but they do work. And for that benefit, you have to put up with a lot of side effects. Sexual side effects, in particular, are tough to discuss, do not go away with time. You can't say, oh, if you just keep taking it, you should get your erectile dysfunction back. That's not what the studies show. So you're going to have to either deal with that somehow, or you're going to have to think of switching to something else. Another bad side effect is the anticoagulant effect of SSRIs, especially if you combine them with another anticoagulant, like ibuprofen or other NSAIDs. If you combine an SSRI with an NSAID, the risk of GI bleeding, as just one kind of bleeding, goes up 900% over a 3-month period if they're on both of those. Now, that can be mitigated by having them on omeprazole or a similar type of drug to reduce the irritability in the stomach, but if they're not on that, you're looking at a big increased risk from this combination. And I just saw a patient recently in my practice who was having nosebleeds constantly, like major nosebleeds, and no one could figure out what it was. But this patient was on fluoxetine and ibuprofen. It didn't occur to anybody that that could be a problem. So we stopped the fluoxetine. Lo and behold, over the next few weeks, the nosebleeds stopped. So be watching for the anticoagulation issue. And suicidal ideation is also an issue for some people with SSRIs. It's double the risk of placebo. It's not a big risk. It's 4% versus 2% for people under age 25, but that's something to think about. Okay, so that leads now to, well, if you don't want to use an SSRI, what else do we have? So we would say consider these 4 other options in that case. And here they are, written a little more clearly. Of these, we prefer duloxetine, because that might be first choice, because it is FDA approved as a treatment for GAD. It's got low sexual side effects, because that's often the issue with not wanting to use an SSRI. It's not 0, but it seems it has been compared with one SSRI directly to look into sexual side effects. That SSRI was paroxetine, and it had less. But paroxetine is probably the worst SSRI for sexual side effects. So it was picking a straw man by the drug company to compare it with that, but they did beat it. So we think that might be first choice, but we got 4 others to think about. But benzodiazepines are not one of them, and I'll explain why in a minute. So let's talk about these 4 alternatives to an SSRI. The first is duloxetine. It is favored over venlafaxine, the other SNRI commonly used, because it has much less effect on blood pressure. The blood pressure effect is probably comparable to SSRIs. The lower rate of sexual side effects I already mentioned, whereas venlafaxine has significant, probably comparable sexual side effects. It is contraindicated, though, if there is liver impairment, and you can get some anticholinergic effects occasionally. Urinary retention is seen at 0.4%, not a whole lot of people, but that's not an issue with some of the other treatments for GAD, so you need to be watching it, particularly in older people who might be vulnerable to that. Dosing of duloxetine would be 60 to 120, no advantage to the higher dose in one study, and it does have some other side effects that are common, nausea, dizziness, dry mouth, fatigue, somnolence, and constipation. And another advantage of duloxetine, it is FDA approved for pain in a number of conditions: diabetic neuropathy, chronic musculoskeletal pain, and fibromyalgia. Those are additional FDA-approved indications for duloxetine. However, it's a myth that this effect on pain is clinically significant in people who are depressed. Now, we're talking about people with anxiety in this lecture. But there's quite a bit of literature examining depressed people who also have pain, and what is the role of duloxetine in them? And it turns out to be very unimpressive, with one meta-analysis finding an effect size of 0.115. That means it was 11% less pain than the placebo. So hardly any benefit. Another review compared the effect on pain with other antidepressants and found the effect size varied from 0.13 to 0.25. So, and duloxetine was right in the middle of the group. It had no special benefit on the pain in these depressed patients compared to other antidepressants. And all those studies where it got approval was all in people who were not depressed. They excluded depressed people from all those studies that led to those FDA approvals. So I don't know if having anxiety plus pain is going to lead to the same concern or not. But I don't know. I think we need to have studies to evaluate that. But it might not give you the benefits on pain that you're hoping for. Okay, moving to the next alternative to an SSRI, we have buspirone. And that is FDA approved, effective at 30 milligrams a day, useful in placebo-controlled trial in abstinent alcoholics, where a higher dose was needed for them, 50. No abuse potential, good side effect profile, little overdose toxicity, no cognitive or psychomotor impairment in driving, no sexual side effects. Looks great, right? But there's only one placebo-controlled trial in DSM-4 or 5 GAD. It got approval on DSM-3 GAD, which is a totally different condition. It wasn't a worrying disorder the way it is now. So I'm not sure if it works so well. And a lot of my colleagues, when I bring this up, say they have serious doubts about how effective buspirone is for GAD. But anyway, it has all those advantages, aside from the issue of its efficacy, so we have it as an alternative. Hydroxyzine is the next alternative to discuss. It's had 5 randomized controlled trials in GAD, reviewed in a Cochrane review some years back. So what is it? It's an antihistamine with less affinity for muscarinic, serotonergic, and dopamine receptors than some others. Now, it's X-rated in pregnancy, though, so this absolutely should be avoided in women who could have the potential to become pregnant, and in the elderly, as I mentioned earlier. But as far as the effect size in these 5 studies, it's not bad. It was 0.45 in a meta-analysis of these 5 studies, a little better than SSRIs. And it has the advantage of no abuse potential, no withdrawal syndrome. It's sedating, like benzodiazepines, which can be good, lack of sexual side effects, less cognitive impairment than benzodiazepines, so it's a significant option. The usual dose is 10 to 12.5 twice daily, and then 25 at night, total of 50. It's commonly used as a PRN also for anxiety because of its rapid onset of sedation, usually within 15 to 30 minutes, has a half-life of 3 hours, and total duration of effect might be 4 to 6 hours. So it gives you a good short-term benefit. Be aware, though, that it can raise QTC, and that usually occurs at doses of 100 or more per day. The European Agency for Drug Evaluation says you should not use it above 100. I do see it being prescribed in doses as high as 200 in my practice, so there seem to be some people not aware of this requirement to keep it below 100 total. And the studies where it worked were using 50. This study by Lorca illustrates the benefit of hydroxyzine and how it works over time, which I think is kind of interesting. On the top, with the circles, you see the effect of placebo over the course of 84 days on these GAD patients measured with the Hamilton A. And here are the hydroxyzine, and there's a benzodiazepine being compared with it in this study, bromazepam. And you can see that first 3 weeks, the benzodiazepine is better than the hydroxyzine. But over the course of the full study, the hydroxyzine catches up and is pretty much the same as the benzodiazepine. So it's kind of working with an antidepressant-like time course to gradually improve the GAD, and it beats placebo by a slightly increasing margin over the course of the full study, which is a nice thing to see. And you can expect perhaps further improvement over the 84 days. So I think it's a good option to be thinking about. Next, we get to pregabalin as an alternative to the SSRIs. Pregabalin is approved in Europe for GAD because of 7 positive randomized controlled trials versus placebo. Some international guidelines recommended first line for GAD. However, oddly perhaps, it was not approved in the United States for GAD. It was twice rejected by our FDA for GAD. And it's been very hard to figure out why. Because we have a law in the United States that says when the drug company sends out an approval letter or a non-approvable letter, if they don't approve something, they send it to the drug company, but there's no obligation to release that non-approval letter to the public. And the drug company has refused consistently to allow the public to know why the FDA refused to approve pregabalin. We tried to find out ourselves when we were doing our paper on our algorithm for GAD. And when we finally got high enough in the drug company hierarchy to someone who could give us the definitive answer, the answer was no, you can't have it. So some have speculated that maybe there was poor results in some of the populations that involved US patients, but we don't have it as an approved treatment. But some in Europe are enthusiastic about it based on these studies. And compared to SSRIs, it seems to have a more rapid onset, helps with sleep, as I mentioned before. It is a dose-dependent effect, and you have to use the higher doses. Over 300 a day is more effective than lower doses. And it is effective in the elderly, too. There is a study in older adults with pregabalin, although there were some people who took falls in that study, so you do have to have appropriate caution. And dizziness is a side effect, somnolence, and increased risk for fractures if you do fall. So some have wondered about pregabalin, since that's very similar to gabapentin. How about that for GAD? Well, unfortunately, we have no placebo-controlled trials of gabapentin for GAD. However, they do share a lot of things in common. They both work for neuropathic pain. They're both anticonvulsants. And gabapentin is frequently used off-label as an anxiolytic. In fact, there's a study in certain chronic anxiety states, post-operative anxiety, gabapentin beat placebo, and breast cancer survivors with anxiety. There was a study in them versus placebo where it was effective. So I think gabapentin could be reasonable, but the evidence base is weak. And the last one I'm going to talk about may surprise you, because clinicians don't usually consider bupropion for any kind of anxiety. However, did you know that there's a double-blind controlled trial of bupropion versus escitalopram, an FDA-approved treatment for GAD? Now, it was a tiny study, only 24 patients. They had DSM-4 GAD, which is very similar to the current criteria, and they got bupropion 24-hour version, up to 300 a day, and that was compared to escitalopram, 10 to 20, a good robust dose of that. They used the Hamilton A and the Clinical Global Impression of Improvement, and the results were the endpoint scores favored bupropion Do you believe that? Their endpoint scores were 5.3 versus 11.4 on the escitalopram-treated people, which turned out to be statistically significant, even though this was a small study. The study desperately needs to be replicated. But other measures in the study, like response rates, remission rates, favored bupropion, and there was no difference in depression ratings. So they weren't treating depression in this study. So since that was surprising, you do have to consider that there's other indirect support out there for bupropion as an anti-anxiety agent. For example, there have been a number of studies of bupropion compared to sertraline for people with major depression and anxiety. And in those studies, reviewed by Trivedi, they found comparable anxiolytic and antidepressant effects with the bupropion and the sertraline. No difference in insomnia or other activating side effects between the SSRI and bupropion. And then there was the STAR-D study. Remember that? The STAR-D study, they tried augmenting people who failed on citalopram. In the second step of STAR-D, they either gave them bupropion or buspirone. And look at the results. 18% remissions with bupropion added to the citalopram. These were depressed people with high levels of anxiety. That subgroup had 9% getting better on buspirone. Wouldn't you have thought that to work better than bupropion for highly anxious, depressed people? Well, it wasn't true. And studies like this, and some of this data has suggested to Mark Zimmerman, my colleague from Brown University in Rhode Island, he thinks we should have bupropion as our first-line SSRI for depression. And finally, I want to comment on why not a benzodiazepine as a first-line option. They are the most prescribed anxiolytic agents worldwide. As a matter of fact, alprazolam is the #1 most prescribed benzodiazepine internationally. And it did get FDA approval at the time of DSM-3. It gives you rapid improvement. Clonazepam, which is much longer acting, also has been used to improve symptoms of GAD while waiting for an SSRI to work. And it does seem to help both somatic and psychic symptoms. So with all those advantages, what about the disadvantages, the bad news? Well, sedation is often problematic. And then there's memory impairment. I'm sure it's well known to everybody that benzodiazepines cause short-term memory impairment. It probably doesn't cause permanent memory impairment, as I mentioned, but there's all this psychomotor dysfunction, falls, there's car accidents. 40% of patients develop tolerance or dependence or rebound withdrawal when you try to stop them. And then here's a particularly problematic concern, reviewed as recently in the Journal of the American Medical Association a few years back. The anti-anxiety effects from benzodiazepines and GAD seem to disappear within weeks in this meta-analysis of the follow-up studies. Then there's the respiratory depression. There's FDA black box warning came out about combining with opiates. There can be fatal outcome from that combination. Then in 2021, they sent another warning letter out to everybody who prescribes benzodiazepines about the risks of, quote, abuse, misuse, addiction, physical dependence, and withdrawal reactions. And by the way, there are no well-established psychopharm interventions to help people discontinue benzodiazepines, according to a Cochrane review. Nothing clearly works. It's a very tough problem. And I've already mentioned that you should avoid them in anyone with substance use disorders. So these are all the negatives why we don't have it at the top of our algorithm. So that is the first step. Now, what if you go ahead with your SSRI, but you only get a partial response? Can you augment it? So we would say you can. There's a few alternatives you might consider: hydroxyzine, pregabalin, and a benzodiazepine. We would not use a second-generation antipsychotic at this point. They have way more side effects. So when would you do augmentation? Well, you want to be sure that this partial response was not due to placebo. Now, that can be hard to sort out, but you don't want to add another drug when the first drug was a placebo. And placebo's effect is very high in GAD in all the studies. So did your patient get a partial response that was a placebo response? Do your best to figure it out. Often the patient, him or herself, will be the best judge of that. But if you really think the drug caused it, you could add one of these other medications for incomplete response. Hydroxyzine has no studies, actually, but I gave you the evidence of its effectiveness as monotherapy, so it seems reasonable. And then there's pregabalin, which actually has a placebo-controlled augmentation trial, adding it to an SSRI versus a placebo, with pretty decent doses. It had a small additional benefit. Why not buspirone? Well, there are no studies of it as an augmenting agent. It was not impressive in STAR-D, like I just showed you, as an augmenter. So it's not a prime option to add to get additional benefit on GAD. Okay, we're now completing our first trial and all those alternatives that we have to it. So we're ready to try something else, a second trial of something. And we think you could try another SSRI. However, we have no studies of this exact situation. Nobody has taken the trouble to study a group of people who failed GAD treatment with a good trial of, let's say, an SSRI, and then gave them something else versus a placebo. We wish we had such studies. But extrapolating from the depression literature, where it seems that when one SSRI fails, another may work, and that the SSRIs are not identical in their pharmacodynamic effects, we think you could try another one, a different one. But you've still got all those options I've already discussed. 4 of them I've discussed in detail. I've got 2 more to quickly mention now, venlafaxine and also agomelatine, and these herbs. I guess I already did mention agomelatine. Oh, no, I didn't. I got 3 more to discuss. So let's discuss them. What about venlafaxine for your second trial? So we think it's reasonable, but duloxetine is a better choice for the reasons I mentioned earlier if you haven't tried it yet. But venlafaxine's had a fair amount of study in GAD, so if you did try duloxetine, you might try it now. Remissions most likely occur when you go to a higher dose, like 225, and it has a maintenance study. We have very little in the way, by way of maintenance studies in GAD, but there is one for venlafaxine, showing efficacy by Carl Rickles. And also there was an interesting comparison with escitalopram and placebo with venlafaxine. Now, it was less well tolerated. There were 13% discontinuations on the venlafaxine versus 5 on placebo, and escitalopram was the same as placebo. So you have to watch out for the dry mouth, drowsiness, headaches, and increased sweating. That may be why people don't want to take it. Now, how about agomelatine? Agomelatine's not available in the United States, so it's not approved in the United States, but it is available in lots of other countries. It's had 20 randomized controlled trials in depression. The overall effect size of those studies is small, 0.24, which may be why it is not approved in the United States. But it is approved elsewhere, and it turns out it's had 3 12-week placebo-controlled randomized trials in GAD, showing efficacy at 10 to 50 milligrams daily, and it has a maintenance study, 26-week maintenance randomized trial by Dan Stein and colleagues. So it looks like a reasonable choice at this point, despite the small effect size in depression, if you live in a country that has it available. It's comparable to escitalopram also in one study. In that study, the response rate was 61% on agomelatine, 65% on the escitalopram. And it's more sedating, so it might be good for those people who can't sleep. And I want to discuss two other treatments at this level of the algorithm, two herbs that are commonly prescribed. So there was this study about 12 years ago comparing kava with placebo in a 6-week trial. It had an effect size of 0.46, I mean statistically significant at 0.46, but the effect size by Cohen's d was a rather robust 0.62, and there were 26% remissions versus 6 on placebo. Has headaches as a side effect. There are cases of severe hepatotoxicity and some other studies with more mixed results. So we have it placed here after the second trial. And another one is lavender oil. That had a study 11 years ago, a much larger study. This drug is a brand product in Germany. And the drug company did a study involving 539 patients. It worked, 80 to 160 milligrams daily. It's available in the United States over the counter. I'm not sure if it is available in Turkey, but maybe someone could tell me. And it was compared to paroxetine in one study. It's marketed in Germany under the brand name Psychotherapy. Okay, so if you have done this second trial but you get a partial response, we've got the same augmentations to offer. But what if that didn't work and you're ready for the third trial? We're getting to the end of the algorithm now. So you have tried 2 medications, maybe 2 SSRIs, maybe an SSRI and duloxetine, maybe one of those other drugs we thought you could consider as alternatives. What's next? We think for the third trial, Node 5, you could now try an SNRI if you haven't already done so. They've got enough evidence and they've got FDA approval. Now's the time to go to one of them. But we have alternatives, like we did before. And here are some additional alternatives to all those ones I've already discussed. And they are, first of all, just listing those alternatives in case you forgot them. They are buspirone, hydroxyzine, pregabalin, bupropion, a benzodiazepine, agomelatine, or herbal treatments. The 2 herbs. So we'll add a couple of more. I'm sorry, I see a misprint in my slide. I mentioned benzodiazepine in the alternatives, but it's actually only turning up now as an alternative for this third trial. And 2 second-generation antipsychotics, quetiapine and risperidone, but we would avoid olanzapine, and valproate. So a few words about, oh no, I don't have a few words about each of those. So let me go back. Can I go back? No, I guess I can't. Is there a way to go back?
Sunumu baştan açar mısınız?
I want to say a few words about the second to last slide. Any way you can send me back?
Sondan ikinciden itibaren bakın. Okay.
Okay, and the one before that? Right, so we're now saying here for the third trial, and you don't want to use the SSRIs or SNRIs that we recommended for the first 3 trials, we now say, okay, you could use a benzodiazepine. It'll have all those pluses and minuses that I mentioned earlier. For the other alternatives, we have quetiapine and risperidone. Quetiapine has a randomized controlled trial, a tiny trial versus placebo in GAD. And it was quite effective. They sought FDA approval for GAD, for quetiapine. The FDA said no. They thought that it has way more side effects than everything else we have for GAD. They didn't think they wanted to allow the drug company to heavily market it, which they certainly would have, so they didn't approve it. However, it does seem to work. And we think this is the place to think about it if you've gotten to this point in the algorithm. Now, with risperidone, we don't have any controlled trials, but we have some case series. If you prefer the side effect profile of risperidone over quetiapine, you might go there for the anxiety, but we would avoid olanzapine. That also has case series data, but it is way more prone to side effects than even the quetiapine, so we don't have it in the algorithm. There is a little bit of evidence that valproate may be useful for treatment-resistant anxiety cases, and way down at the bottom of the slide, there it is. You could still consider it at this endpoint. Okay, now I'm ready to give you my final remark, which is, in studies of algorithm usage, better results occur when you take time to explain and educate your patient about the evidence base for and your reasoning for what you're prescribing. That helps them understand what you're doing, why you're doing it, what the science behind it is, and increases their confidence. We strongly recommend doing that. And this algorithm gives you some tools for doing that with the citations that we have for the evidence base. Nevertheless, despite all that, any algorithm, certainly ours or anyone else's, should never be followed rigidly. You add your clinical experience or other special considerations that you perceive in your patient, why they should be an exception to what the evidence might seem to point to based on these studies I've been citing. You might have a very good reason for thinking you shouldn't do any of what we recommended, but there's something else that seems to fit. Now, you should be able to explain that to your patient, that we have all these FDA-approved treatments, but I want to give you whatever. And here's why I want to give it to you, and why I think it's, for you, it is just the thing. And you probably should document that in your notes as well, why you are giving that peculiar thing for your patient, which has maybe not a whole lot of science behind it, but maybe has your clinical experience or some other factor that you've come up with why you think it would be perfect for this particular patient. So you explain that, you document that, and then it's certainly reasonable, and sometimes you're going to get brilliant results doing just that. So that concludes this talk on generalized anxiety disorder algorithm, and I am ready for any questions that you might have.
Thank you.